implant options and biomaterials in ACL. So you may be doing a lot of ACL reconstructions. What are your preference of implants or preference of screws that you are using? What screws are you using?
So generally we use big screw.
Big screw. Peak screw or biopsical screw? And what is the difference between a peak screw and a biopsical screw? So basically, bioabsorbable screw is made up of a material which is called as a PLLA, polyl-lactic acid. So this was a screw which we have used a lot in the past. It is a very good screw in the sense it is a soft screw, and we have done a lot of them. But nowadays, in some patients, there is some consideration of sterile reactions, cavity formation, and serous discharge in very few patients. So slowly PLLA screws is becoming obsolete, and most of the companies have reduced the use of bioabsorbable screws or PLLA screws, and some have even stopped the production of bioabsorbable PLLA screws. Okay, and because of these reactions in some patients, so it's not very common. But let's say if we are doing about 20-25 cases, one of the patient may present to you with a serious discharge, and the problem with that is if this patient present to you with serious discharge, you will always have a doubt in your mind that this is infection, and it becomes a bad cycle, and it becomes very difficult for the patient to explain that this is not an infection but this is a sterile discharge which is coming. Similarly, it can give rise to cavities inside the bone. So they can have cystic cavities. When they dissolve, they can cause cystic cavities. So that's why the use has been declining over the years. So over the years now, because this has these problems, now the usage of the screws is diversified into two main type of screw. One is a peak screw and one is a biocomposite screw. So we'll discuss about both of them. So peak screw is a polyethyl ether ketone. Peak is a thermoplastic. So this is a heat resistant medical grade plastic material. The advantages of peak material is that it is not bioabsorbable, it is bio-inert. So there is no reaction of the body towards the peak material. So whenever you implant it anywhere, there will be no reaction by the tissue, by the muscle or by the bone. So not only in ACL surgery, now peak material is used a lot in other implant surgeries as well. So nowadays there are plates available of peak material, there are screws material available of peak material, you have spine screws, cages available which are in peak material, the rods are now available in peak material. So peak material is one thing which is coming into picture. So other advantage is very high tensile strength, it is heat resistant, it is chemically inert, and as I told you, there is no reaction over the long term, and it is radiolucent. So you will not be able to see the see even the screw in the MRI, or even if you see, you will see even a very faint line. So most of the times a peak material is a radiolucent material. Its melting point is around 343 degrees Celsius, so very high. So even it is autoclavable. So if you want to autoclave the peak screw, you can autoclave. Although we don't autoclave it as a routine, but if you want to autoclave that, it is possible. You can easily autoclave that without any problem. The second form of screw which is more commonly used nowadays is a biocomposite screw. So biocomposite screw is a mixture of PLLA and either hydroxyapatite or beta TCB, beta tricalcium phosphate. Now this material is called as biocomposite because they can integrate with the bone. So it is hypothesized that this material will integrate with the bone. So there will be bone formation in the area where the screw is integrated. And the recent most advanced to that is what is called as a RegenSorb screw. This is launched by Smith and Nephew. This is a biocomposite and screw with holes. So it has got fenestrated holes inside the screw. So what happens is when you put this screw, not only there is it's made of biocomposite material, but it has holes all around. So actually what happens is the bone grows into the screw. So the fixation wise it is a very strong screw, and it makes a very good sense that it integrates. But the downside to this is you cannot remove it. Just as if you have an uncemented stem, it is very difficult to stem if there is a porous coated stem. If you want to remove it, if you want to revise it, is very difficult. Same if you want to remove a Regensob screw. I have tried it once, it is not possible. It will be, the bone will be totally ingrown into this. So this is one thing. So bioabsorbable screw, and at today's time we are advising less, advocating less because of the sterile reaction issue. Occasionally, very very occasionally, 1 in 100, 1 in 200 biocomposite screw may have sterile reaction issue, but this is much less as compared to the classical PLNA screws. So nowadays either PEEK or biocomposite overall. If you have consideration of cost or economic constraint, you can even use titanium screws. They are good and they have a good fixation and they are inert and they have a good strength. So occasionally you can use titanium screws as well. Now buttons, coming on to the buttons. Now buttons for the femur fixation, you have two types: fixed loop and adjustable loop. Fixed loop is the more old ones, and they are available in different loop size. So 15, 20, 25, 30, and people have now made smaller sizes. So 12, 10 is also available in some companies, and 35, 40, 50 like that is also available. But more commonly used is 15, 20, 25, 30, 35. Most commonly. Now fixed loop have an advantage that the chances of errors are less with a fixed loop, because once you are good with your tunnel length and your diameter of reaming, usually it will flip properly and it will not be an error. So these are more positioning wise, they are more complication free, but the downside to that is you need to have a very precise measurement of the tunnel and the reaming length. So if you have supposedly 30 tunnel and if you have 15 number screw, 15 number button, then you need to ream up to at least 22, 23 to have a good flipping distance. So that is the calculation that you have to make every time if you are using a fixed loop. Now adjustable loop button, you have an advantage that you don't have to make the calculation. It will take some sort of error calculation, it will adjust. But the downside to it is that it has got two issues. Usually it is represented by the tightrope group. So usually the problem is, supposedly if you pull very hard, it will come out into the soft tissue and it can be lying over the TFL. So occasionally if you see the X-ray post-op, it is not on the bone but it is in the soft tissue. So this problem usually can occur if you pull them hard. So if you are using an adjustable button, you have to be very sure that you are pulling it very slowly or lightly. You have to pull it slow, and you have to mark it at the length of the femur tunnel. So you have to flip it at the proper position where it is there. Now initially when tightrope was launched, it is single suture, leading suture, and this problem of flipping was difficult. So now they have revised it to two threads, so that you have a proper feeling of flip when it crosses the cortex, and so you don't overdo it. Occasionally the other problem is occasionally it is into the tunnel and you get a feeling of flipping. So that is only the other issue. So, and the third issue with the adjustable loop device is it can prematurely close. So if it is closed, you are stuck. It will not open up again. You cannot release it because it is a one directional thing. You can only tension it. You cannot release the tension back. So these are some issues with adjustable implant. But yes, the advantages are you don't have to do calculation, number 2. And number 2 advantage is you can do tensioning even after fixation of the tibia. So you can do little bit more tensioning as compared to a fixed loop device. Because in fixed loop device, once it is fixed, it is fixed. Once it is fixed, you can still do a seesaw motion and do a fixation. The last thing that has come up now is PEEK buttons on the femur and tibia both. So traditionally these buttons which we are using are titanium buttons. Now there are PEEK buttons also available for femur and tibia, although they are very decent and the long-term studies are not there. Okay. So this is about the implants that we use in the ACL. The other thing which we are adding nowadays is an internal bracing. So it is a concept which is evolving. It is still not proven, and it is still not internal bracing. It's still not. It's not a consensus that it should be used or not to be used. But by and large, we are using for a long time, and it is pretty safe to use it. Basically, internal brace is a fiber tape kind of a thing which we loop over the button and we tie it in a separate tension over the tibia. So that is actually it acts as a seatbelt effect, and it prevents the re-rupture rates, and it is extrapolated that you can increase the speed of your rehabilitation if you are using a internal brace. So these are the basic things that we do. That is regarding the implants which we use for ACL. Any other questions? Biomaterials or implants of ACL, if you have any questions. So now company-wise, you can use any company implants. So as I told you, most of the companies have these formation of screws. Smith and Nephew has got a very good screw, so it has got a good range. So if you talk about Smith and Nephew, they started with the BioCI brand. So BioCI brand is a PLLA brand, PLLA screw. Then they come up with the BioCI HA, which is BioCI, which is PLLA HA combined. It's a biocomposite screw. Then they have a Regenso brand, as I told you, this is a biocomposite and integrative screw. And they have a Peak screw as well. They have a RCI screw, which is a titanium screw brand. So they have a very good spectrum. Similar screws, very good with screws with Zimmer Biomet, Stryker, even Arthrex. And even Indian companies have got good Peak material screws like Osteocare, Biomet, Biotech. They have good Peak ones, they have got good Peak material screws with them. So if you talk about biocomposites, French companies are the leaders. So most of these biocomposite materials, it is coming from the French companies. So different companies, they are importing from the French companies.
Sir, result-wise, is there any difference in the type of screw we use?
So the result will depend on the tensioning that you put. So once you have put the screw in the right tension and the screw is well fixed, the material of the screw will not matter. But what we need to consider is if the screw itself is not generating any problem. That is what we are seeing. So bioabsorbable screw were invented that they will be absorbed over time, and so the revision surgeries will be easier. But unfortunately that did not happen, because when the bioabsorbable screw melt, they leave a void which was not filled up by the bone. So the revision surgery was anyway not easier. So this was one of the reasons again which leads to less usage of bioabsorbable screws nowadays. So most of the companies, even Smith and Nephew, even Biomet, they are not promoting bioabsorbable PLLA screws anymore. So now if you use a biocomposite material, it is extrapolated that this screw you have put, that area will be slowly filled up by the bone. So if you are doing a revision surgery, it will be easier. So that is the philosophy. If you are using any screw which is permanent, like a Peak screw or a metal screw, the screw will leave a void when you remove it. So if you are doing a revision, there will be a void which will be remaining. So that is it. Overall, fixation wise, it depends on the tensioning that you put on the graft. So once you put any screw, if your fixation strength is correct, your tensile strength is correct, all screws will be open. Any other questions relating to ACL fixation techniques or ACL surgery? Now there is a all inside pattern of surgery which is emerging. So in that surgery we have loops on both the sides. So it has a loop on the femur and loop on the tibia. So you don't use screws. So there are buttons on both the sides, and both the sides have loops which can be tensioned. So this technique you can tension on femur and tibia both. And you have a free loop with a button on the tibia.
So, but like this was devised to reduce the incision, or
so all inside ACL surgery traditionally has got two advantages. It was initially described by use of retro-reamers. So retro-reamer will be bone preserving surgery. So the number one advantage to me for all inside is a bone preservation. So whenever you do, you don't violate the cortex. So you preserve the bone, and it is easier for revision. And the other thing is people used to take incision on the hamstring. So if the incision was taken on the back to reduce, so anterior incision is reduced a little bit. That is it. So the advantage is you don't use screws, and it's a suspensory fixation on both femur and tibia.
Strength wise, it is more Is it less in comparison?
So now
to the
still
traditional-
there is no consensus. So it is still strength wise, long term result wise, almost they are similar. There are no papers which suggest that this is better than this. But the advantages of all inside is it is more tensionable. So even if you fix the graph, you can do tension after that. That is number one.
That is
But the downside is again the Bunge effect is there.
Mhm.
So aperture fixation is not there. So both of them has their positive and negative. So still it is not very clear whether one technique is superior over the other.
Cost wise, the flip cutter will cost more.
So now about the cutters or the devices that you use for the reaming. So there are different companies have different devices. So Striker has got a very good device. This is called as a retro reamer. Arthas has a device which is called as a flip cutter, and then other companies are now coming with their retro reaming devices. So the all suture, if all inside, if you want to do, you can use retro reamers of different companies. Obviously that adds cost to the suture, but you can do it with the standard tunnels also. In that case, you don't use the flip cutters, but you use femur and tibia tunnels, and you can use the buttons on the other side. So the same technique of graph preparation and same technique of tension.
Post-op protocol, rehab protocol remains
Almost the same. Almost the same. Yes.
So now we are seeing people are using more and more tunnel dilators. So what
Yes.
is its
So that is very useful. So what happens is when you are specifically in tibia, when you are doing reaming, it eats away the bone. So when you are using a tunnel dilator, it actually does not eat away the bone. It compresses the bone on the periphery, thereby increasing the fixation of the graft with the bone and with the screw. So yes, theoretically speaking, tunnel dilators are useful to make the bone stronger for integration to the graft and to the screw. So yes, it is. Although sometimes it is not practical to use dilator all the time, but yes, dilator is a promising concept to increase the density of the bone surrounding the tunnel.
So when you are using dilator, so we should ream.
So you use a ream 8 and you use 9 dilator.
And graft size will be.
And you have dilators coming in 0.5 increment also. So you can ream 8. If your graft is 8.5, you can use 8.5 dilator. Like that. Okay. Very recent advancement nowadays is oval reamers. Very recent oval reamers. So it is said that the size of the ACL is not actually exact round. It is an oval insertion. So people have come up with oval shaped impactors to make oval tunnels. It is not very accepted, but is the recent most advances. Because exact size of the ACL is not round. If you see native ACL, it is a oval shaped insertion.
So when we do the revision surgery and we remove the this screw, so the next time we should use more one size bigger screws.
So revision is a different scenario. So revision is 1 stage and 2 stage. If you have a very high amount of bone loss, you may need to do a 2-stage surgery. So you need to do bone grafting packing in one stage, and then you go second stage and do the ACL. If you don't have such amount of large bone loss, then you can do a single stage. But obviously you will need to fill up the bone voids. And personally, I would use a biocomposite Regensoft kind of screws in those cases.
In second case.
In the if you want revision scenario, if you are doing a single stage revision, and if I am to use, I will recommend a Regensoft kind of a screw, which is biocomposite and integrated. So it will fill up the void, at least the void which is there. You fill it up with the graft and the screw, and slowly this void will be decreasing in size. So preferably you use biocomposite integrative screw, biocomposite biointegrative screw, Regensoft kind of a screw. That is a better screw. If you want to do it a single stage and you want to use a screw.
Can we remove the screws? Like if the person has ACL surgery 1 or 2 years.
So revision scenario,
No, not
primary.
In trauma scenario, like if
Yes.
patient comes-
So if the patient has got a metal screw, you can easily remove it. Titanium screw, you can remove it with your regular screwdrivers. If the patient has a PEEK screw, you can remove it, but the problem is that it is not visible in IIT. So you can remove, theoretically you can remove it, but it will be difficult to remove it because the screw will not be visible. But you can remove it. If you find the screw, you use it as screw head and you can be able to. Bioabsorbable screw will melt with time. So it is very difficult to remove them. I mean, if it is a biocomposite or integrative screw, it is very difficult to remove because it is integrated over time.
Like if there's a ACL is done in a person and he's sustaining a trauma next time, let's suppose proximal trigger, then you want to fix it. So is there any like time gap that during this time we should not?
No, you can do it whatever you want. And as I told you, most of the screw you can remove it. Na? So if there is a metal screw or PEEK screw, you can easily remove it.
Time duration after this surgery?
Doesn't matter.